Good afternoon, everybody. It's Heidi Simpson with Leading Age Minnesota. Thank you so much for joining us today. We're going to talk about Minnesota's infection control surveys for assisted living settings. I've just got a few housekeeping announcements to go through before the webinar gets started. You received a number of documents in addition to the PowerPoint that you see before you. There are 4 on the right-hand side in the drop-down box. It says handouts 4. That just happens to be that there's a notes version of the PowerPoint before you, and then there are 3 additional documents that will be referred to a little bit later on in the program, but want to make sure that you don't miss those and that you have an opportunity to take care of it, advantage of looking at those resources and using them if you would find them helpful. Speaking of the drop-down box on the right-hand side, a way for you to participate in this learning experience is to type a question into the question box and send it to the presenter. At the end of the program, when time allows, or at another point in the program, if there is a natural break, we will answer as many questions as we are able to during the program. Now, a little bit later on today, we'll be sending an email to you if you were the person that registered for the webinar. In it includes a link to a very short evaluation form. If you could fill that out and complete that online, it's very helpful. We find that very helpful as staff for giving us feedback on the webinar if there's additional things that we can do short of making COVID-19 go away, which we wish we could, but we can't. But if we could help you with other educational programs and services, please do let us know. So we have a lot of ground to cover, so I want to make sure that I give a very quick but brief introduction of the presenter this afternoon. Her name is Kari Everson. Kari is our new director of clinical care, and she's a clinical consultancy for Leading Age Minnesota. She has her own consulting organization called Uboya. She is a very key and important part of our Leading Age Minnesota team, serves on our COVID-19 internal task force made up of staff. She's part of the group that is getting information out to members on a very frequent basis, and is one of the lead staff in our very popular coaching rooms program. Also want to let you know that she has experience as a provider working in the field of older adult services, in addition to having some pretty awesome credentials academically as well as licenses. So you've got somebody very knowledgeable providing very current information on assisted living surveys and what you need to do to remain in compliance. So Kari, I'm going to turn the program over to your virtual audience.
Wonderful. Thank you, Heidi. I appreciate it. Apologize in advance. I have 2 very sassy dogs that bark every time the mailman comes to town. So I think that's what's happening down there right now. So I apologize for that. I do want to let you know we're going to cover a lot of ground, and Heidi did talk about putting a question in the questions box, which we will try to get to as many of those as we can. If we aren't able to get to all of your questions today, as we do in our Friday huddles, so every Friday we have a Friday huddle relating to COVID-19 and talk about things that happened during the week and answer a lot of member questions. If we don't get to them, then I get a transcript of all of the questions that were asked, and I'm happy to reach out and answer those questions via email afterward if we have some left over. If you don't attend the Friday huddles and you'd like a link to be able to do that, if you don't receive the member message, because the Friday huddles are announced in the member message on Tuesday, Wednesday, Thursday, if you would just type that request also into the questions box, then we'll get you registered so that you start getting those daily messages and have the links for the COVID huddles on Friday. That's really good information, especially in this time of what's happening with COVID and all of the ramifications that we have. So we're going to talk a little bit about AL surveys and some of the things that are happening in AL infection prevention surveys. So a couple of things to talk about. I sent out several pieces of, several documents, one of which is a Medicare, CMS, Center for Medicare and Medicaid Services memo, and those are usually geared toward our friends in the skilled nursing communities or in the nursing homes. MDH has adopted those survey criteria for assisted living. So that's why you have that, so that you have some of those tools. And so we'll talk about that just a little bit later on. So we're going to talk about what do those survey requirements look like, and how do we implement those into housing with services and assisted living communities where we've not normally had to be accountable or provide some of that information in the past. For care center staff, a lot of this will be a refresher for you. You likely look at these memos all the time and have this information at hand, but if you've joined us today, we're happy to have you, and I'm happy to answer questions as I can. We're going to talk a little bit about the infection control policies that we need to have in place in order to have a successful survey. And then we're going to talk about a few best practices to prepare for a focused infection control survey in your community. So as I mentioned before, one of the documents on the right is QSO 2029, and this is a memo that came out outlining a couple of items. One, what the COVID-19 focused survey for the nursing homes looks like, and there's a checkbox list on there and some resources that tell us and tell the surveyors what they should be surveying for. And so this is good information to us, because then we have an idea as to what they're looking at, and we have an idea as to what we can review, make sure we have in place, and then prep. And then we also have a copy of the entrance worksheet. So much like in normal assisted living home care surveys, the surveyors will come in and have an entrance conference with you, and you'll have information that you have to provide. So the worksheet that is included in this memo is specifically for the COVID-19 infection prevention and control focused surveys. The other thing that you have that I sent out was the Minnesota announcement back in March 19th of this year. That memo has information in there that MDH has adopted guidelines developed by CMS for nursing homes and is extending them out to additional residential settings, such as housing with services, AL, and arranged home care providers. MDH also stated in that same document that as CMS guidance and any future revisions of those guidances come out, and that means that they're going to adopt those and they will continue to apply to assisted living settings. What we know is we're coming into another survey cycle where they are going to be out and doing surveys in housing with services, in assisted living with arranged home care providers, in which you will receive a citation now. When they were doing their surveys earlier in the year, March, April, May timeframe, they were calling these monitoring surveys, and they were not providing a citation or a deficiency based upon anything that they observed at that time relating to infection prevention. But that has changed in the last month, and so now they are coming out and doing this, and they have received direction and a plan from the higher ups that they will be conducting these surveys, and some of you may have had them already, and surveys coming up in the very near future. So what they're going to look for, essentially, this is listed on your document, but they want to look and see that is your infection prevention program effective? Are you dealing with the right standard and transmission-based precautions? Because as we know, there are universal precautions, contact precautions, and transmission-based precautions that are all rolled together in working with COVID, and it's important to understand which precautions we're using and where. So they do like to see that. They're particularly focusing on screening practices, both for our visitors and for our staff and residents. So we're going to do a little bit of talking about that. And then, of course, they look at policies, and then also do some looks at our education, just to see if we've given the education that we're required to give. And each of these areas is covered under a particular section of that CMS COVID-19 Focus Survey worksheet. And so these sort of tell us where we'll be looking and where we'll be focusing as we go through and look at what we've got in place now. Also, just a reminder that with the essential caregiver guidance that came out last Friday at noon, if that is something that you're going to be looking at, not to forget to incorporate those into your infection control and prevention plans and into any policies and procedures that you may be looking at. Now, you have until July 25th to do that, but when you're looking through and getting ready for survey, now is a really good time to remember to update those, because sometimes we forget to update documents once we've written them and we think we're in good shape, and we are for a while. So just a reminder to update with that essential caregiver. So another document you have linked over there in the right and that you received in your email was the survey entrance worksheet. And they're going to look at this and they're going to ask for some things right away. I always find, and we're going to talk about getting ready for a survey and prepping, that the more efficiently and effectively you can get the surveyors these documents, the more they like what's happening. It tends to be a little bit more positive, and you usually have a little bit better experience unless somebody decides to go down a rabbit hole during your survey, and that sometimes happens. So they're going to ask for your census and of course a list of your residents with their room numbers, which is what they normally ask for. One of the additions that they've added in now is the resident list of confirmed or presumptive COVID cases within your community, because they're going to focus on those charts. They're going to focus on those residents, and they're going to take a lot of look and do observations likely of those clients that should be in transmission-based precautions. So they're going to want that list, and I would expect them to definitely focus there when they're in your building. And they also want the name of the staff person responsible for the infection prevention and control program. And the state of Minnesota has given guidance that there should be someone designated in your building to do infection prevention and control oversight and supervision. It doesn't have to be a separate staff member for assisted living right now. There are no special hour requirements or anything surrounding that. Unlike with our SNF partners, there's a little bit more concreteness around that, although not a lot. But you do have to have a staff member responsible for that. So they're going to ask for that person's name and contact information, and we can pretty much ensure that they're going to interview that person. You're going to go through the entrance conference where they're going to tell you why you're there. And then within 1 hour, what they're going to ask for is schedules of the nursing staff during the time of the survey, which they routinely do, and that key personnel list. They're going to want access to your electronic records or a way to get information out of them. And then they're going to look at your policies and procedures. So the policies and procedures that we have to look at for COVID are mainly centering around screening, personal protective equipment, what we're looking at for transmission-based precautions, emergency staffing plans, those types of policies and procedures. So they likely will not look like the policies and procedures that they normally ask for. They'll be those COVID policies that you have been working so hard on over the last 4 months and working to update. So that's what you'll get with the survey entrance. And so I did list that survey worksheet for you. So the next thing we're doing is we're going to go through the different sections of the CMS Focus Survey tool. I know that for nursing home folks that are on this call, you likely have seen this, and this will be a lot of review of things that you've already seen. For our AL colleagues, though, however, this is not something that they're used to looking at, and you may or may not have seen that. So we're going to just take a little while to run through this piece. So the first section they're going to look at are your standard and transmission-based precautions. They will do observations in this area, and they will look at your policies. So we can expect that what we're going to see are surveyors going through the building, and they are going to be doing observations of staff doing their hand hygiene. They will be checking to see if you have alcohol-based hand rub or other hand washing, hand hygiene materials around the community, and you should have a lot of them. What I am hearing from feedback from the surveys are a couple of things. One, they want to see a lot of hand hygiene signs and social distancing signs, and they want to see them everywhere. So in the past, we may have posted things a couple of places, but they want to see them in each of your households or neighborhoods or units, whatever terminology that you use. They like to see more than I think that we would normally expect. I've been a little surprised by the number of signs they wanted to see, and they want to see staff prompting residents to follow those standard precautions, provide hand hygiene for residents, and be interactive in that area. We're going to talk a little bit more about contact and droplet precautions. There right now, just as a reminder, what we have is a situation where the department has asked that everyone wear a face mask, a surgical face mask, unless you're in a crisis PPE or contingency PPE plan, and that people are wearing eye protection. So a lot of questions that I get, particularly based on the standard precautions, is, do we have to wear all of the appropriate PPE as if someone were COVID positive after an admission during their 14-day quarantine period? And the answer to that question is yes. They want to see everyone in full PPE, including gowns, for those residents that are returning from the hospital or newly admitted to the community, regardless of where they are admitted from where they are admitted. However, if you are in a situation where your PPE is exceedingly low and you are trying to conserve your PPE based upon your inventory, it is okay, if need be, that they wear those face masks and eye protection. So just a little heads up on that, because that's a commonly asked question that I run into. One of the other things that I am finding that they are asking for a lot is cleaning and disinfecting of reusable equipment. Oximeters, particularly if they don't have their own. Now in our housing settings, they often do, but I also know that we have those admissions where someone doesn't get a glucometer in right away when they are admitted. And so lots of communities, for either emergency situations for people that are not routinely known to have hypoglycemia, or with things like oximeters, those are not being disinfected appropriately between residents, and we're finding that that is becoming an issue with our survey. They also are going to ask us to take a look at, our resident care. So do we have sustained community transmission? So we know that an outbreak can be one case of COVID or a presumed case or a respiratory chain of symptoms in 2 or more people. So are we looking at sustained community transmission, and have we looked at how we're implementing our policies and procedures, and are we transitioning between those things when we're going through, and are we being agile? They're going to look at our group activities, community dining, and resident isolation issues. Those have been very prominent lately, talking about resident isolation. That is part of the impetus for our new essential caregiver guidance. And they're going to be looking at transportation, or what we're doing with residents that are leaving on medically necessary appointments. So when we're looking at group activities and communal dining, there's been a little bit of a disconnect lately on, is it allowed, is it not allowed, how does that work? And so group activities and communal dining are allowed. They have been allowed, with the caution that we are social distancing people appropriately, that staff are wearing the appropriate PPE, and so we're able to do that. Not everyone has gone to doing that because they either have space issues, staffing issues, or other things, but know that they are allowed, but they will be serving and observing those group activities or communal dining to ensure that we're following those precautions. They will also be looking at what we're doing about resident isolation. So while many people are still on the fence about whether or not they're going to implement the essential caregiver guidance, I would take a look at that and determine pretty quickly whether or not you're going to implement that, and what your rationale for implementing or not implementing is, and that you have that information documented. And then we have the residents leaving for medically necessary appointments. So they're going to take a look and see how we handle those residents when they return. So it's important that we are doing good hand hygiene, that we're having them wear those masks while they're gone on those appointments, and that when they return, we're doing resident screening and doing hand washing and taking their temperature to make sure that we're keeping with our policies and procedures. In the infection surveillance area, we're wanting to look at first symptom surveillance. So those signs and symptoms of respiratory infection. We have added now some signs and symptoms that are different from what we once thought. So some really odd ones, like a decreased sense of taste or smell, or there have been people that have had a sore throat. Sometimes they're not presenting the way that they should present. So it's a good idea to ensure that you have good symptom surveillance logs, both for your resident and your staff. They will check those. They're going to ask to see them, and they're going to maybe ask to take copies of them. Testing surveillance, we want to make sure that we've got the number of people that have been diagnosed, and what are our protocols surrounding testing. There was new testing guidance, or I should say not new, updated testing guidance that came out last, I think it was this past Monday, although it might have been just before then, that gives some more information on testing. So now's a good time to sit down and take a look at your testing plan, determine if you want any changes to that, and make sure that you're following it. Sometimes we get things on paper, and we forget that we've implemented them, or not everyone is implementing them. You're going to want to have a surveillance plan and a plan for communicating information to staff, residents, and family members or responsible parties. At Leading Age, we have been encouraging as much transparency as possible with residents and staff and family members. We're finding that being open and discussing our plans and what's happening has really provided good outcomes for our clients and for communities in total and sort of in general. So we would continue to do that. They really are going to look at, do you have a process for this communication? So what we're finding is it's really good that we've communicated everything at the beginning, but they're also going to want to look and see, do you have a process in place to be able to communicate any changes in guidance or any changes in your policies or procedures? Do you have an ongoing education plan or communication plan with your staff and with your residents and stakeholders? I think we're good out of the gate, but we forget sometimes that communication is just as important. What I will say is, talking to many of you and talking with other members, people have been really, really on the ball with communication, and I just want to put a shout out there to all of the hard work you're doing on that. It's a really important part, and I think our members have done a really great job with giving that information and communication and trying to alleviate some of that worry and distress, and that has really helped in our settings. So surveyors are going to want to see your plan. If you don't have a plan, it's a good idea to write one down and get it in your policy or procedure now. For visitor entry, they are going to look at a screening process as well. Same symptom screen, same temperature. There's been a slight change in the screening guidance. So what they're saying now is, if anybody has a temp over 100 degrees, that could be a potential issue. They're also saying that if you have a staff member or a resident that screens with a temp greater than 99 degrees multiple days in a row, that may also be an indicator. We're going to have some definite ideas about what the restriction criteria is. Does this mean that they can't come in? Does this mean that they need a nurse to come and look at them? And those, and we also should have some sort of instructions to give visitors with entry, upon entry rather. So I know that we don't have a lot of open visitors right now, but we still do have compassionate care visits and those essential medical personnel or staff that are coming in to do things like hospice visits, home care visits. Perhaps you're having your vendors not drop off outside your building, but come in. And so there do need to be some instructions for that. And they are going to look at that, they're going to observe for that, and they're going to ask for that. It's probably good to note at this point that many of these processes will be observation processes during your survey, and they are trying to do most of their policy review off-site. So you're going to find that they will do probably more follow-up than normal and ask for more paperwork and documentation after exit, because they're trying to decrease the amount of time they spend in the community based upon community spread and trying to decrease COVID transmission. There's a staff piece where we have staff education that needs to be done. And so they're going to ask for your staff education logs. They're going to look at things like infection control education. So if you have not updated that or had not updated it close to the time when COVID started back in March, now is a good time to do that. You should also have some COVID specific training out for your staff, and that should have been taken care of. And then they'll also look for things like, if you have a person at the desk that is screening visitors and staff, have they had the appropriate education to know what to do with those screening information, where to take it if they have someone that they think perhaps may have an issue with their screening, and are they able to demonstrate that they have some understanding of that? So if you haven't provided that education, or you haven't documented, more likely, that you've provided that education, now's a good time to go back and do that. So they're going to want to look at staff monitoring logs, and they're going to look for blanks in those logs. And sometimes people have been throwing those logs away, and surveyors have come in and asked, so they're keeping them for a short period of time. And when the surveyors come in, they don't have a couple of days of logs to show them. So we might want to just take a quick peek at that. And then they're also going to check to make sure that someone is monitoring the screening. So after the screening logs are complete, after we've screened staff for the day, where do those logs go? Who's looking at them? And are we doing anything about what we're finding? So if we're finding blanks in our screening, or that certain staff or essential personnel have not been screened, How are we following up on that? That's usually where they sometimes get us, is in that documentation or following up with what we found in the documentation. So just a reminder that it's also good to take credit for your work and at least have some indication that you've looked at the logs. If you've looked at the logs and they're complete, sometimes a RN initial at the bottom of the logs is a good idea. Otherwise, if there's something that you have to do for follow-up, it's good to keep some notes or good to document that so you can remember when survey comes in what you've done about that and can direct them in the appropriate place. Whoops. We talked about communication with residents, family, and primary contacts or representatives. One of the things that I think that is going to be essential for communication now is your communication on your essential caregiver plan. If you're not going to do that, then we need to let people know. If you are going to do that, you need to let people know what that looks like when it starts and what the parameters are surrounding that. We have some links on our Leading Age COVID coronavirus website that has some good communication tools that will be posted that you certainly can use. But good communication should be out there, and we should have documented our attempts to do that and have a good communication process. So some of the policies and procedures that you're going to want to have available when surveys come through, we talked about an emergency staffing plan. I think that there is an emerging staffing plan on the department website now, or SEOC is working on one. And SEOC is doing some education on emergency staffing and contingency staffing, crisis staffing. So if you've not already seen one of their education webinars, you may want to reach out. They know they're doing a pilot program and trying to do some education now. So there is that. Otherwise, you should have an emergency preparedness plan that already encompasses things such as your fire plan, your tornado policies. It's a good idea to also put in your emergency preparedness plan, your COVID policies around staffing, and develop in the future or look at next phase of just an emerging pathogen policy. It's one of those things that the nursing homes are supposed to have in place as an emerging pathogen policy. I don't know that we're looking at that as closely or really had that on our radar in the housing situation. So I would suspect that's something that we're going to have going forward, and so it's a good time to plan for that now. They'll look for a visitor screening policy, a staff screening policy, staff education, which I apparently thought was important enough to put on here twice, a PPE policy, and then I would make sure that you've added to your infection prevention policies that were already in place. If you have them regarding transmission-based precautions and then what that means particularly for COVID. If you didn't have a transmission-based precautions or other type of contact precautions, transmission-based precautions, airborne precautions plan, now is a good time to look at that policy and procedure because we're going to need to make sure that those are implemented in place. So that's just a quick overview of the form that the surveyors are using or looking on to be able to come in and do your survey. Now I'd like to transition into where are the biggest infection control tags. After reviewing information that we have on hand, myself, John Lips, my colleague, Julie Apold, another of my colleagues, spent some time looking at this, doing some tracking and some trending and getting some information together on when they come in, where are they citing us and why are they citing us? So there are 9 of them. I wish I'd had 10 or 5 or 8 or something that sounded good, but we ended up with 9. So 9 is what we've got. Those areas are staff screening, which we talked about, PPE, surveillance. They're looking heavily on equipment and environmental cleaning and disinfecting, particularly hand hygiene. We've seen a lot of citations for hand hygiene, social distancing, resident screening, your isolation practices, and your staff education. So these are the areas we're going to focus on now. We're going to talk a little bit about some of the examples that they've cited and what they're writing up in those deficiency statements. So the first one is staff screening. And what we're finding is there are staff that are still screening themselves. The department wants to see active screening. And active screening means someone else is asking the questions related to symptomology. Someone else is taking the person's temperature and they are recording that information. Staff cannot screen themselves at this point. Now, it doesn't have to be anyone that has any amount of necessarily clinical background. but they then do have to be trained on what they're supposed to be screening and then what they should do with that screening. There have been citations because screening was performed in a resident care area. So they would have staff go to the nurse's station and they wouldn't have them do this screening at the entrance or close to the entrance. Sometimes they would have the screening at the entrance, but in order to be able to go to work, they had to go to the nurse and report their screening, in essence, walking through the resident care area, negating the reason for the screening. There have been citations given because of crowding during the screening process. So people are waiting, they're waiting to go through their screening, particularly at shift change. And during that time, they're not maintaining social distancing and they're getting cited for not maintaining their social distancing. We are also seeing areas where some staff haven't been screened at all. And so we know we're supposed to screen our paraprofessional staff. We know we're supposed to screen our nursing staff, our visitor staff, but guess who we're forgetting to screen? We are forgetting to screen our director of nursing and our housing managers or our administrators. And so those two particular staff positions are not always screened when they're coming into the building. And we have to remember that the DON needs to be screened too. So that's one of the areas where they are looking to see if truly management staff is getting screened when they're coming into the building. There have been deficiencies or citations written because while we're screening our own staff, they have not always been screening hospice staff. Now, I also understand that sometimes hospice staff or other outside agency home care staff or people that are coming in to provide those essential services squeak by us without being screened. And it's a good time now to be able to do that communication and remind them that while they're coming in, they need to be screened. I think we're all pretty used to that, but we're still seeing some of those people squeak in and not get their screening done. And of course, when that happens, there's always a surveyor standing there to catch us not doing something that we're supposed to be doing. We have found that there are some of those individuals that are assigned to complete this screening that actually did not get any training, or they got the training and it's not documented. And then there was a citation, many citations that we saw because there was a policy on individual screening, but it was unclear of what to do in the event that something triggered on the screen. So if someone had a temperature of 101 degrees, there wasn't any guidance as to what to do with that person. Do we have them step aside in another room and have a nurse talk to them? Do we ask them to just go home and come back and talk to someone later on? What is the outcome of that? And they do want to see that if you have a non-medical person doing that, that they know what to do about that positive screen. And then we've seen the incomplete documentation of screening activities. So a lack of logs or logs that are missing pieces of information. And lastly, that lack of oversight. So we know that there's a process in place, but who's looking at it, who's reviewing it, and who's holding others accountable. There we go. Sorry about that. I had a little bit of an issue getting my screen to advance. The second area of citations we're going to take a look at is PPE. So there have been several tags for PPE, which I know for many of the nurses and the nurse managers and the administrators, this is a frustrating tag. We do a lot of education on PPE. We have done a ton of education on PPE lately. And so one of these PPE tags, I would suggest that being able to take a tour around your building, walking around to making sure that people are using them and doing good PPE audits is an excellent way to try not to get these PPE tags. Although I am very well aware that we cannot control what our staff are doing out there when we're not out there. So just a little consistency on the PPE front. So we've seen that there is the failure to use PPE for residents on droplet precautions. And so what that looks like is there may be a sign on the door indicating or near the resident apartment indicating that the resident's on droplet precautions and that staff were to wear the appropriate PPE, but staff would go in without the appropriate PPE on anyway. We had particularly saw this with housekeeping staff or dietary staff And what the answers from them usually are is we didn't think that that pertained to us. We thought that was for nursing staff only. So I think it's a really good idea to make sure that your ancillary staff, not just nursing staff, understand what PPE they are supposed to be wearing and when they are supposed to be wearing it. What they wear in the kitchen can be different from what they wear when they're out interacting with residents, providing activities, doing housekeeping, or providing meal service. There's a lot of issues with the source control masks, and I'm sure everyone remembers when the masking question started. Do we wear a source control mask? Do we wear a surgical mask? How do we know what to wear when? And they now have that contingency PPE grid out on the state of Minnesota website. If you don't have the link to that or you can't find it, you can either email me and let me know, or there is a link to that on our Leading Age Coronavirus webpage so that you can pull that off and take a look. So what we're finding is that when the policy stated that a staff is supposed to wear a source control mask, that oftentimes in the communities without them. I think this was earlier on, but we're still seeing some of this. We are also seeing citations given because a family member, usually a hospice, a resident that's on hospice that was doing a compassionate care visit without wearing a source control mask when they were in during their visit. That's happened on multiple occasions. The family member, of course, then told the surveyor that they were not instructed to wear that mask. And so that is why when we first talked about screening, when people are entering the community, that screening should be done and then instructions should be given to anybody that is not your staff member as to what PPE they should be using and how they should be navigating throughout the community. So there have been mutations for that. We're seeing a lot of this. I don't know if you guys have seen on social media, on Facebook or other places like that, where there are people with their masks on their head or hanging from their ear or under their chin. I don't know if they're collecting stray food or what they're doing, but we have seen many citations because people were not wearing their PPE appropriately, whether it be their mask or their eye protection. We have had people that wear their eye protection on top of their head, and so surveyors have cited for that. Or we've got masks in all sorts of places except for where they're supposed to be on your face. And what we mostly see is people have pulled the mask down and it's resting just underneath their nose, so it's not protecting that part of the respiratory system. And what staff will lots of times say is, it fogs up my goggles. We've heard that. It's difficult to breathe in the mask. It doesn't fit properly, so it's slipping down. So one of those audits that we should be doing when we're out looking at what's happening in the community is, are people wearing their masks or their other PPE correctly? And if they're not, and they have complications with things like it continues to fall down, or I'm having trouble breathing in that mask, that we take the appropriate steps and document that when we're looking at those mask issues. We've seen citations that come because staff have touched their face or they've touched their mask and then haven't performed hand hygiene after that. We're getting a lot of lapses in our PPE and hand hygiene protocols. I did see one survey that I was looking at where the nursing assistant or the unlicensed personnel, the home health aide, however you term that in your building, was in the break room eating, and they had taken their mask off and set it down on the table next to them and was eating with their mask sort of laying about all over the place, sitting right next to another staff member that had done the same thing. So it's important that staff understand how to store those masks between uses after the end of a shift or between their break times, or if they're not going to be using them within the community. Lots of people are using the paper bag method, which is excellent. That's the best method to use. Those paper bags don't keep that moisture in, but we have to make sure that our staff are doing the appropriate techniques for storage of those masks. And it's really easy to take it off and set it down next to the table. And I have to laugh because I did that the other day, and then I'd throw my mask away and start over again. So we can all do that. And lastly, what we're looking at are residents who are not wearing their source control masks when out of their room. Now, I did put a donning after leaving the resident room on here because for those communities that have the ability to take off their PPE or doff their PPE in the resident room right before they leave, you should do that, and the appropriate waste receptacle should be in there. However, there are some places where that is not possible, so making sure that you pick a good spot to be able to take that off right in that resident's doorway and have a receptacle for discarded, dirty, or disposable PPE is a really good idea. These donning and doffing things can get us sometimes because we get very used to what we're doing and we have lapses in practice. And it's especially difficult, I think, for us in assisted living and housing with services right now, because we don't do a lot of these transmission-based precautions types of things. COVID is really the first time that we have been hit with a very prolonged use of gowning, face masks, eye protection. It's not something that we routinely do. We may use a piece or part of that on occasion when someone has a C. diff or something like that. But we're finding that it's been difficult for staff to transition. So I just put that on as something to take a look at when you're doing the donning and doffing. So surveillance. What we're finding is a lack of a surveillance system. Now, in the nursing homes, we see a lot of tracking, a lot of trending, a lot of disease diagnoses, what organism, what did we do about that? Did we test? And they're pretty used to that. What we need to have in the assisted living area is they want to know if we've been looking at residents that have had signs or symptoms, and what that means is, if you have a household or a floor or an area of your community where we've seen residents with signs and symptoms of COVID, they're looking to see if we're being a little bit more proactive. So the requirement now is doing your resident screen and temperature screen once a day with a codicil that best practice is 2 times a day. But if we find that there's a resident in our program and we're used to doing our resident surveillance once a day, perhaps it's time to bump that up to twice a day to make sure that we're not having other residents show up with signs and symptoms. They want to see what we're doing about that. And so if we're not demonstrating what we're doing about that, that leaves us open for a potential deficiency in that area. A lack of a data analysis. So we've had facilities collecting data, but the facility didn't demonstrate that they looked at it or that they had investigated or tracked infections to determine if there were patterns or trends, to see if they were having spread within the community, and then put those things in place to help reduce that risk of community spread. Some communities are doing that, but they're not doing it in a timely fashion. So they may have had some of these resident symptoms or screening concerns, but they have waited 3, 4 or more days to take a look at that and then implement something. I think that's pretty understandable given the really high pressure, crazy changing system that we have been living in for the last 4 months. And we have not been able to be as agile or to pivot as quickly because we were spending a lot of time, particularly in housing, trying to understand what PPE we should be using when, what does the surveillance system look like that we've not normally had to have in place, and how do we put these things into practice that we've not had to consider highly before. I think that people are getting a lot faster at this and people are getting a lot more comfortable with this. So it's a good idea just to sit down and make sure that you haven't lost this piece of it. I think we're getting to a period of a little bit more calm than we have had in the past. And so it's easy to drop good practice sometimes when we're not as fearful or we feel a little bit more confident and comfortable in what we're doing. We will find sometimes that those tracking or surveillance logs don't include some of the residents. So we've done surveillance on everybody on the unit, but we forgot to do the surveillance on Mr. Smith in the corner. He either dropped off our system, we didn't get it entered into the EMR if you're using that to do that and do that surveillance or tracking for the residents. So it's important to make sure we're not missing anyone. And then there have been some paper document. There was a citation where there was a paper documentation, and when they asked why they had stopped doing their tracking of symptom screening, the nurse just couldn't find any more forms, and so she didn't ask for any more. So it's a good idea for those of us that are going out and watching these practices to make sure that those are getting done on a daily basis. Heidi, I'm just going to stop really quickly right now because we're about 15 minutes from the end and I have a few more slides to go through. But do we have any recurring questions that I need to address?
Oh, we have a few.
Oh no, okay.
Okay, so I'll have to go fast. So there was just, and I'm going to get to them in chronological order because it's only fair. So just very quickly, there was a request for the survey entrance worksheet. Didn't see it in the document sheets. Is it something that's part of one of the documents that was shared?
I believe it's in the QSO 2029 toward the end.
Okay.
I will check that though, and if it is not, if I'm not recalling correctly, because sometimes my brain fails me, certainly I can give that to Ashley, and when she sends out the recording, she can send that document out as well.
Awesome, thank you. And then just a quick thing about, let's see, we have a couple questions about gowning. Did you say that in assisted living and new admission, do staff need to be gowned for the first 14 days going into their apartments?
Yes, they do need to be gowned for the first 14 days when going into their apartments, unless they are in contingency mode with their personal protective equipment. So you have a huge shortage or you don't have enough, then you can do eye protection and masks. But otherwise, yes, you're expected to wear gowns for that 14-day.
Okay, all right. And then there were two questions, so I'll ask them as one, but they relate to staff screening logs. Do you have any recommendations for best practices? I noted that you didn't mention a specific amount of time, but was wondering if you might have some best practice recommendations for the group.
For how long to keep those logs, or
Yeah.
for what logs to use?
How long to keep? Yeah, how long to keep the logs?
So the last time we had Jonathan Lips checked on this for us, and right now we're just asking that people keep their logs for from when they've started until now, until we can get some clarification on what the department is looking for. Also, I think if you keep them quarterly, that's for a quarter, that's likely fine. But
Okay.
we're just advising people not to throw them or shred them just yet until we have a good handle on what's happening with these surveys.
Sure, because the health department's learning too.
Right.
Okay.
All right.
Next question, when the resident returns from a medical appointment and they are on a 14-day quarantine, do staff have to wear gowns in addition to mask and face shield?
Yes.
Okay, all right. And then there was one, this was on the last one is, can active screening be a second staff person observing the temperature and asking about the answers to the questions?
The second staff person, it can be a second staff person. So usually this question comes up when we're talking about like a PM to night shift transition. Sure. And so they'll say, when the night shift comes on, can another home health aide, nursing assistant, whatever you call them, screen your overnight shift staff? Yes, you absolutely can, but you have to take their temperature. The state has been very, very clear that they don't want staff to take their own temperature. They want someone else to take it and record it. And they've given a ton of deficiencies on that. So unless I haven't heard something recent, it's probably just in everybody's best interest and your best bet to have someone else take that for you.
All right. Okay, we're good for now.
Great, thank you. Hand hygiene. The thing I'll say about hand hygiene is, well, we know that people get in trouble because they haven't completed it. What they're finding though too are some of these pretty standard deficiencies where they haven't done it when they're changing their gloves or when they've had contact with their face mask or appropriately during resident care. They are going to want to see proof that you've done hand hygiene audits. And actually, if you've had a case of COVID in your building up until this point, they are going to ask you for your compliance percentage for your hand hygiene. So audits. So if you're doing hand hygiene audits and aren't keeping track of which ones people did correctly and which ones people needed more education on, now is a good time to do that because they are going to want hygiene compliance rates. Social distancing, communal dining, smoking areas, the lobby. These are places where we've got people kind of milling around, residents milling around, visitors milling around, those visitors that are allowed in. And what we're finding are things like tables in the dining room are not 6 feet apart. And surveyors are going in with a tape measure and measuring. So it's good to know that. The tables are maybe poorly spaced. And so you've got one area where you've got a couple of people that are like still too close together in their chairs. Smoking areas, if you still have a smoking area, which not many do, but I do know some that have them, they are asking that you put some designations as to where people can sit in your smoking areas because they're finding a lot of places where that is not appropriately socially distanced. And then in the lobby. They are suggesting that perhaps if you've got some way to designate traffic flow in your building, that is a good way to sort of combat that, and putting X's on the floor or some sort of other demarcation that tells people where they can be. We've all seen them if you've been to Target or some other stores. They've got a lot of those markings on the floor that tell us if someone's ahead of us, you stand here. So that's been a good practice to sort of stave off that social distance or that social distancing deficiency. Resident screening, this has been the same sort of issue as we've had with the staff screening. So I'm not going to spend a whole lot of time on it, but it's the same sort of things: lack of documentation, not having done it, not keeping those logs up to date if you're doing paper charting. Some people are doing it in the electronic record, and so that's a little bit easier to keep a hold of. But as always, those audits to make sure you don't have any blanks in your documentation are good to do, because we all know that they go in and take a look at that. Isolation precautions. So we have found that maybe one of the trickiest things that we've had to deal with in this time of COVID was implementing our transmission-based precautions and knowing what PPE we should use and in which situations it should be used. There was a lot of confusion about masks, especially when the source control came out. And we have had so many guidances sent out to all of us. There have been CDC guidances, there have been MDH guidances. MDH has cross-reference guidance from other places, and they have changed so quickly. It is easy to lose track of that, and it's easy to lose whether or not we have the most current practices implemented. And we are finding that surveyors out in the field sometimes don't know what the correct practices are themselves, and they're giving a lot of funny feedback. So when we're looking at these isolation practices or some of these PPE issues particularly, it's not a bad idea to ask questions and find out what the surveyors are looking at, because this might be something that you want to take a look at later and do an appeal for, or have some other avenues explored with your local friendly neighborhood attorney. I don't know. So, but these precautions have been changed, so it's good to make sure that we're keeping up to date with them. I usually recommend that someone in the community at least go in and be assigned to check some of the usual suspects. So a little trick that I can tell you is, if you Google CDC new postings, I think that's the right phrase, it will take you to, it'll pop up with the CDC page that gives you the most recent guidances and the date that they were posted. So if they posted 3 on July 15th, those will be listed at the top, and then they go in chronological order all the way back to the beginning. So if you've missed something from the CDC, that's a good place to find it. An MDH, it's not so easy. And so I find that you have to do some hunting and pecking. So watch your member messages for some of those new guidances that come out, or have someone assigned to go on every so often and check those things to see if anything's been updated. We had some questions about the new admissions, and so we have to make sure that we're keeping new admissions hopefully admitted to a private apartment with a private bath. Sometimes that's not what's happening, and they have people that live with them, and that we're keeping them in that 14-day quarantine period and using our transmission-based precautions during that time. The other thing that I would say is, if we have residents that become symptomatic, the more quickly we get them into transmission-based precautions, the better off we are, and the less likely we are to have a deficiency result from that. For staff education, I find that most of the education is not truly an absence of education. It is an absence of documentation of education. So now would be a really good time to go through and make sure your rosters are updated, that you've entered things into any of your online or electronic learning software systems, and that everyone is present and accounted for. I'm finding that, again, most people are trained, but what's missing is the documentation. The other thing that we're finding is that there is no, we talked about a communication method to make sure, or a mechanism to make sure that people are up to date on the most recent changes to your policies and procedures. And we're finding that that is what is also not getting communicated timely. So if your original staff education is done and documented, great. But then we also need to look and see, how are we documenting education of updates? Are you having staff meetings? Do you have a communication book where you're documenting those things? Do you have a staff constant contact email going out? Do you have some other way of doing that? And how are you tracking that to make sure that those people have been given that education? So we'll talk a little bit about survey preparation best practices. So review the entrance worksheet. We talked through that. Please take a look at the focus survey for nursing homes form from CMS. The next thing is it's always a good idea to create a survey binder. So in the survey binder, some of the recommendations I have are put those policies and procedures in there that pertain to COVID that we talked about. They're going to ask for them. They're going to want to see them. You don't have to hand it over to them right away when they walk in, but it's good to have handy and at the ready should they ask for them, because there's less strain and stress in having something at your fingertips rather than having to log onto the computer or find the policy binder and get that copy for them. So I would have those policies and procedures in there. I would also have your COVID-19 action plan, whatever that looks like for you, that encompasses your emergency staffing process, what your surveillance plan looks like. Have your hand washing audits in there, or a week's worth, or whatever that looks like for you. Because if they want to see them, then you've got them. Your surveillance logs, maybe a week of surveillance logs, just in case they want to take a look at those. Might as well put a list of your residents in there and have some way of maintaining a current list of your residents that are COVID positive or that have some presumptive symptoms that you can keep and have handy. Maybe it doesn't go in your binder because that's a hard place to update it, but it's a good idea to have that going so that you don't have to try to go and create that list when they walk in. That is always stressful, and you always worry that you're missing someone. And then of course, it's always nice to have the names of those facility staff, their locations, their phone numbers, and your infection prevention person that is designated for infection prevention written down and available, because then you can just hand it over. And then lastly, I did link over on the side and have sent out the ICAR action plan. There is the ICAR department at the Department of Health has an action plan that they have asked that everybody complete. So if you haven't had a chance to go through that, now is a really good time to do that. Excuse me. And if you haven't gone through it in a while, now is a really good time to go through and update that. It's a really nice working plan and really covers most of the areas that we've covered and most of the areas that survey is going to come in and look at. So if you do that and have that plan ready and have a copy of it, they're likely going to ask for it when they come into the building to make sure that you have something laid out. So having that ICAR plan in the survey book is a really good idea. So that's a lot of content and a lot of stuff we've gone through, and a process that you're not as familiar with as normal for those surveys. So I think, Heidi, we've got like 3 or 4 minutes left in case we have any other questions that came in on the question hotline.
Oh, yes. And as soon as I said we had no more questions, they started just coming right in. So
well, good.
I think we have about 2.5 minutes. So
Great.
We will get them as soon as we can. So can you quickly revisit the culinary staff PPE and how that's different from the direct care staff?
Sure. So in the culinary department, when they are in the kitchen and they are not working directly with residents, they can wear a source control mask as opposed to a surgical mask, because I know everybody's very worried about their surgical mask supplies. We seem to have hit a nice plateau and seem to be okay with our PPE, but I do know that in the southern states, we do have some surges going on, and that may affect our PPE supply chain. So you can use those source control masks in the kitchen or non-resident contact areas. But if you have a staff member that's going to deliver trays or deliver food, and that will be in contact with the resident, or maybe they're cutting up or preparing that food so that they can eat it, then they have to don a surgical mask if you have them for proper infection control.
Okay, thank you. And then this is another question related to being quarantined. This individual thought clients no longer needed to be quarantined for a medical appointment unless it took longer than 4 hours to see a medical provider.
Yeah, let's talk about that one a little bit, because I'm still getting a ton of questions on this, so I'm glad somebody asked it. So the guidance from the department is, if a resident is leaving for an essential medical visit, let's say they're going to have dialysis or they're going to see a surgeon for a follow-up examination, if they're going to those essential appointments, you do not need to quarantine them when they return. If they have an overnight stay in the hospital, they are asking that you quarantine people. Everything in the middle, mom comes and takes her, or daughter comes and takes her mom out to Target to go shopping, or they take a ride in the car, or they go to some sort of outing that you're not sure about the risk level. In those situations, it's up to the community to determine whether or not they feel that the outing was higher risk. If they feel it is, they should quarantine. If they feel it is not, then they do not need to.
Okay.
So I hope that helped. But
go
you
ahead.
have an email address if you need me to send that to you in writing.
Okay. All right. So we are at 3:30. We have a number of other questions, and what I'm going to do is send the question list along to Kari, and hopefully we can get that out to you with the post webinar evaluation. It depends on how quickly we can get to the question log, but we will follow up with the group and let them know answers to the questions that we were not able to get to. Kari, there are about half a dozen of them or so. So Kari, well done. There was a lot of information to get covered in the hour, and you did it very well. And Kari is used to speaking with other staff, and so I was a little worried about speaking by herself, but I think you did a fine job. So
well, thank you, Heidi. I appreciate that. And I appreciate everybody who attended today. Thank you so much.
yes, thank you for joining us for learning. And just a quick reminder, we'll send you an email with the quickie follow-up survey and then answers to questions that we were not able to get to. So thanks again for participating, everybody, and have a good rest of your day. Bye-bye.